Hi, Dr. Saheli Kapat. Today I am presenting spectrum of encephalocele. We know encephalocele is protrusion of the intracerebral content through a defect in the skull. The term encephalocele more precisely referred to cases with external protrusion of both brain and meninges. Defect is usually covered by the intact skin. Encephalocele may be part of several other syndromes. Prevalence in Asian population, it is 1:5,000 in birth. The encephalocele is classified in according to the location. It may be anterior, parietal or occipital. Anterior encephalocele again divided into the location. Depending on the location, it may be frontal or basal. In frontal, there are three types of encephalocele, that is the nasofrontal, nasoethmoidal and nasoorbital. In basal encephalocele, it is subdivided into 5 classes, that is the sphenoorbital, sphenomaxillary, transethmoidal, sphenoethmoidal, sphenopharyngeal. According to this classification and the location, total cases of encephalocele are divided. In our first case, it is a 22 years primary gravida presented at our clinics at 20 weeks 3 days of gestation. She was referred to our center for second opinion USG. Her triple marker are negative. In anomaly scan, it shows that frontoethmoidal encephalocele on the right side. Baby has lemon-shaped skull, microcephaly with parietal partial obliterated cisterna magna are there. Right renal pelvis are dilated. It is 4.9 mm, that is UTD A1. Fetus has flat faces and mild hypertelorism. They plan for termination of the pregnancy, and termination of pregnancy occur in the periphery from where the patient was referred. Karyotyping of the product are done, that came out normal. Other genetic tests like CMA or advanced genetic tests are not done. This was the picture of the fetus. It showed the lemon-shaped skull and frontal encephalocele showing here with the flat faces, and the third picture showing that brain matter protruded out from the ethmoidal in the area of the ethmoidal region. So it preferably a frontoethmoidal encephalocele. In second case, it is 33 years second gravida at 21 weeks 1 day gestation, came to our clinic for second opinion USG. Her down skinning report was not available. In anomaly scan, it shows that head are grossly small in size and deformed with overlapping skull bone. A small 1 mm defect seen in the right high parietal bone, through which atretic brain matter is seen herniating out. Other organ like spine and renal pelvis, everything appears normal, and cardiac image is also normal. The couple opted for termination of pregnancy. Here karyotyping and other advanced any genetic tests were not done. These are the image of the USG that show the small head of the fetus and small atretic brain matter protruded out from the skull defect. So it is atretic encephalocele. Here both the cases diagnosed with encephalocele is associated with microcephaly, and termination of pregnancy is done in both the cases. So we come to the conclusion that encephalocele are the most often part of the specific syndrome, that is Meckel-Guber syndrome, are associated with high risk of recurrence. But in those two cases, we can't able to come to the specific diagnosis, that is it Meckel-Guber syndrome or not. For that reason, they need CMA. That test were not done both the cases. And non-syndromic encephalocele are probably related with neural tube defect. In both the cases, there is no associated as such open spinal bifida or anything else detected. But in the first case, there are UTD A1. That may be case of Meckel-Gover syndrome, but not confirmed. So detailed ultrasound examination is mandatory for all the cases, because ultrasound is the main tool for diagnosis of encephalocele or any neural tube defect. Thank you.